Mrs. Shivlyajat, a 45-year-old woman, non-smoker, non-alcoholic, non-diabetic, hailing from Brahmanbaria, presented to us with history of multiple joint pain for last 2 years, shortness of breath for last 3 months, progressive gain of weight for last 2 months. According to the statement of the patient, she was reasonably well about 2 years back. Then she developed joint pain. The joint pain first started in the small joints of the hands, but it gradually involved the other small joints and even large joints of the hands and the feet. The pain was symmetrical and it was insidious in onset, gradually progressive. It was mild to moderate in intensity. The pain was more in the morning and it was associated with morning stiffness for up to an hour. The pain increased after a period of inactivity and it decreased after activity or exercise or after taking analgesics. The patient also complained of shortness of breath present for last 3 months. The shortness of breath was insidious in onset, gradually progressive. Initially, it was only after moderate to severe exertion, but now it's present even after mild exertion or at rest, corresponding to a MRC grade 3 to 4. The shortness of breath is not associated with any diurnal variation or any seasonal variation. There is no history of chest pain, palpitation, orthopnea, or paroxysmal nocturnal dyspnea. It's associated with dry and distressing cough. The patient also gave history of increasing weight for last 3 months. She gained around 15 kg in that period, but there was no history of any change in her dietary plan or any change in activity level. She also complained about thinning of skin and easy bruising. And she had difficulty raising from chair and also difficulty combing her hair, and she felt very weak. There is no history of low back pain. There is no history of photosensitivity, oral ulcer, or alopecia or hair loss. There is no history of tightening or thickening of skin. She did not have any history of recurrent DVT or stroke episodes. She did not have any dry mouth and dry eyes. On further history, on drug history, the patient told us that she visited multiple physicians and she has been taking tablet methotrexate for last 2 years regularly once a week along with tablet folicin. She also took repeated courses of steroid after exacerbation of her disease, and in total, she took 3 courses of prednisolone 30 to 40 milligrams, which was gradually tapered. And currently, she is continuing to take tablet prednisolone because it makes her feel comfortable. She also took over-the-counter NSAIDs and also NSAIDs prescribed by the physician, along with the proton pump inhibitors. On past history, she did not have any history of any past illness apart from being ill for viral illnesses. But she did not give any history of any hospital admission for any serious illness. She is a housewife. She is non-smoker, non-alcoholic, and all of her family members are in good health. She is menstruating regularly. There is no history of any early fetal loss or any other adverse pregnancy outcomes. She did not give any history of any other illnesses. She is immunized as per EPS schedule, and she is also vaccinated against COVID-19. Then on examination of the patient, I have found that the patient is anemic. The patient's face is swollen, it's a moon-like faces, and the skin is thin. There is multiple bruises in the skin, and there is a reddish purple abdominal stria present across the abdomen. On examination of the musculoskeletal system, there are deformities in the hand, such as swan neck deformity, buttonia deformity, Z deformity, and ulnar deviation. There is gross wasting of thinner hypothenor muscle, and there is dorsal guttering. The joints are also swollen, especially the PIP or proximal interphalangeal joint, metacarpophalangeal joint, and the wrist joints are swollen. There is presence of rheumatoid nodule. On palpation, there is grade 2 tenderness in the above mentioned joints, and the patient's temperature is raised. The pulses, the radial pulse, are normal and bilaterally symmetrical. On movement, the patient has restricted joint movement and decreased functional capacity. On examination of the respiratory system, the patient has reduced chest movement. There is bibasal, fine, and inspiratory crackles, which does not alter after cough. Further examination reveals she has evidence of proximal myopathy, as it was difficult for her to get up from a sitting position. Other system examination reveals normal findings. So, with those history and examination findings, my provisional diagnosis is this is a case of rheumatoid arthritis with diffuse parenchymal lung disease with steroid induced proximal myopathy.